Good afternoon. There's some seats in the front for those of you that are just coming in, and over here to the side as well. So good afternoon. My name is Nish Kazbaker. I am ASHP's immediate past president, and on behalf of the ASHP Board of Directors and staff, I want to welcome you today to the town hall focused on residency training. Before we begin, can I just get a show of hands? How many program directors in the room? Woohoo! It's quite a bit. How about preceptors? Some of you double dipping on that one. Coordinators? And then most of all, do we have any residents in the room? All right, a couple. Cool. Well, thank you all for being here today. Thank you for your involvement in residency training, your dedication, your commitment to preparing the next generation of pharmacy practitioners and leaders. Your dedication is really appreciated more than ever because you know that we're confronting a lot of significant issues in organizations like workforce challenges, financial challenges, and so as you're all aware, residency training really offers a structured opportunity to allow pharmacists to hone in on their clinical skills, expand their knowledge, and prepare for the challenges they face in their careers. At ASHP, the Commission on Credentialing and the Accreditation Services Office are committed to creating a program structure and a clinical learning environment where residents can thrive and achieve their postgraduate professional practice goals, as well as supporting program directors, preceptors, and department leaders in delivering this high-quality training. Over the past year, I'm sure you've noticed that the Commission on Credentialing and the Accreditation Services Office has been very busy and has made many exciting updates intended to do exactly that in terms of high-quality training. In July of this year, PGY1 Pharmacy, Community-Based Pharmacy, and Managed Care Pharmacy residency programs implemented the newly updated and harmonized Competency Areas, Goals, and Objectives, or as we've referred to, KGOs. These KGOs ensures that PGY1 residents develop the skills and abilities critical to providing our patients the best care possible and are prepared to take our profession to the future. But that's not all. Thank you so much for your feedback, for your engagement. The Commission on Credentialing and Accreditation Services tackled high-impact issues important to programs across the nation, and that included addressing regulations surrounding multi-site residency program structures, preceptor qualifications, and the administrative burden of running a high-quality training program. Today's session is designed to review these exciting updates, discuss additional developments, answer your questions, and hear from all of you. There are a couple microphones in the room, and then folks will be walking around with microphones as well, because we want to hear from you and continue the great work that's been going on. So thank you again for your dedication to training and all that you do every day to hope that this will be a great meeting and you'll get out of it a lot of information as well as provide our team information. I will now turn the podium to somebody I knew when I was 18 years old. I went to college with this man. I'm so proud to be able to introduce one of my BFFs to you today, Sam Calabrese, ASHP's Vice President of Accreditation Services, who will introduce to the panel to you. Thank you.
Well, good afternoon, everyone. Last year when I was at this podium, I told you I'm a newbie, so bear with me. But it's a year and a half. I'm hoping what the promise I told you last year, which was give me a year and let's see what happens. So I'm hoping today we get at least some positive kudos about some things we made, some changes we made, and then give us the next list of items to tackle moving forward. So welcome. Intimidation, they made the room bigger for me, so I'm glad we could bring more folks in to get your questions answered. We're going to try to get through the slides as quick as possible because the real reason we're here is for you, to hear what questions you have, what comments you have. And that's why I bring the panel of experts with me, right? So just to introduce our panel, Pat Fuller is our chair for the Commission on Credentialing, pharmacy clinical supervisor as well for Nebraska Medicine. Our Some changes to the panel as well, new faces. Julie Daggum is our new Director of Residency Accreditation. Eric Grace is next. He's our Director of Standards Development and Training. Amy Haida Cardillo is our new Director of Operations. You all know Lisa Lifshin, Senior Director of Pharmacy Technician Accreditation and Residency Services, as well as, I know most of you know, Andrea Roberson, our Director of Process and Quality Improvement. So they're going to be here to help answer some of those tough questions or the ones that I don't want to answer because it's a bad answer, and they'll take care of it for you. Again, I will promise you what I did last year as well. I may not know the answer, but I will get the answer for you. And it might not be the answer you like, but it will be an answer, right? So we'll definitely get those out to you. I know Pat's going to introduce this phenomenal section over here, but we could not do this without the COC members who help us with the standard development, and then all of the outstanding surveyors who are on our team who work tirelessly to make sure we have quality residency training out there. So he'll introduce these folks, but they're here to help answer the questions as well. So I will turn over the podium to Pat, who will give you a little update.
Well, thank you, Sam, and thank you, everybody, for joining this afternoon. I know when I was in my first year or two as a program director coming to this, it was definitely a little bit of an intimidation, but hopefully all of the friendly faces of the survey panel here will welcome you all, and all of the great changes that we've made in this past year will be welcoming for everybody so that we can provide the best training experience to our residents in the best environment possible throughout our wonderful country. So a couple things before we get to the introductions. We're going to go over the actions that we have, summarize the actions that the COC has made this past year. We're also going to speak about a little bit from the accomplishments and all of the great updates for you guys. Sam will talk about residency growth and the residency match. And we heard you, yes, loud and clear from last year's town hall in Anaheim, and we're going to highlight some of the key questions and answers from the 2023 town hall. And we'll segue into continuous process improvements and some other exciting changes. And there is now a little section called Did You Know? And even up to, I think, about 10 minutes ago, I was still learning things and things that I did not know. So then we'll open it up for the infamous Q&A, and I already saw Frank. So Frank, wherever you're at, have you come on up. But on behalf of, I wanted to first and foremost say it's been an absolute honor and a privilege to serve as the chair for the Commission on Credentialing this past year. Truly a highlight of my career. I've been blessed to work with Sam, Julie, all of the wonderful people in the Accreditation Services office, from all of the contract lead surveyors to the lead surveyors to the admin assistants. Got to meet and work with just phenomenal people on the Commission. And what I'd like to do is introduce those that are currently serving, and then those also that will be concluding their service at the end of this month. And then we have the next slide will be for the new members. So when I call your name, just please stand, and then we'll please hold the applause until after we're done announcing the new members. So succeeding me will do a phenomenal job in Jonathan Lackrow. Next, we have Carrie Pickworth, and I want to thank Carrie for all her mentorship and guidance for me over this past several years being on the commission, and we thank you for your service too. Then we have Nadidi Badger-Plange, Nadidi here. We have Nicole Clark, Sandra Cuellar, Katie Derry, Jennifer Hamner, Jesse Hogue, Winter Smith, Todd Walworth, Kelly Good, our APHA representative, Suzanne Nesbitt from ACCP, Tom Pomfret, AMCP, Sarah Ray, representing AACP, Deanna Berg, our resident member, Rick Ricciardi, our public member, and Lopa Patel, our other public member. And also, many thanks to Nish, our past president of ASHP and current board liaison. So let's give a round of applause thanking them for their service. And for the new members, we have the new vice chair, oncoming vice chair would be Katie Muir. We have Julie Bartell, Kelly Bobo, Tara Jellison, Michael Knaus, Nancy Shapiro, and Zach Kraus. And we look forward to your service on the commission. Thank you. So some of the actions in this past year, in March of this year, 49 new programs were accredited, along with 199 existing programs that were reaccredited. And then going to August of this year, 97 programs, new programs were accredited, along with 121 existing programs that were reaccredited. And when we go to the regulations, the multi-site, within the regulations, if we can rewind the clock, we would take you back to March of 2023, where there was some updates to the regulations related to the multi-site residency programs. Well, in March of this year, we decided, and again, this is one example where we heard from you. We want to thank all of the community members for their feedback, but we paused changes to the multi-site and wanted to just get another perspective. The majority of the concerns were from the PGY1 community-based programs because of the greater impact that these changes were going to be having on those programs. We knew that the terminology was confusing, the definitions included some arbitrary percentages, and there was those limitations on the distance and the number and the distance between the sites. So we heard you and we worked hard and we approved a reimagined framework which simplifies and eliminates the single and multi-site terminology. The arbitrary percentages were eliminated. Going forward, using the standard in the survey process to really help identify potential concerns. And it is hoped that this will allow for creative designs and innovative future models, and for those programs that are currently in existence and have been great programs for many, many years, some decades, to continue to evolve and innovate, and also for the birth of new programs to be innovative and to become more numerous. And existing programs that are impacted on these reimagined changes have until July 1st of 2026 to adjust their program structure, and we're really excited going forward about these changes. Other regulations that I'm excited about, and hopefully we are too, RPD approvals. We revised the verbiage to reflect that the Accreditation Services Office now approves the program directors. The verbiage for the provisional approval has gone away, and we removed the 1 year to allow for flexibility and the use of professional judgment in determining the next program directors. And with survey updates, we went ahead and clarified the survey team composition for extenuating circumstances, knowing that sometimes the last minute the survey team has to be adjusted. And the timelines for the sites to provide the survey itinerary also have been updated. And just other minor wordsmithing and removal of duplicate verbiage. Additional updates to the standard: the DEI has been revised in the recruiting elements to align with the changing state laws. And really, the guiding principle is that the ASHP is still committed to the mission-driven, systematic efforts to recruit and retain a diverse workforce and a residency training force, but it's going to be guided by the organizational mission, vision, and values. We've also eliminated the conference and/or educational days as time away. Hence, hopefully, maybe we will see an even bigger increase in residency and preceptor attendance at the conference here this year. And we also updated the diversity resource guide, and that was posted on ASHP's website in October of this year. Now for the even gets better. Every slide, it just gets a little bit better. We eliminated the RPD and preceptor qualifications related to the role modeling and ongoing professional engagement. So if you may recall, it was having to meet 4 things in 3 categories, or maybe it was 3 things in 4 categories, or 5 things in 2 categories. We always had to refer back to the standard, right? So it was confusing, and so we want to make sure that we know that there's great preceptors out there. They're still practicing. We don't want anything to push preceptors, shy them away from precepting. And so we've eliminated this in the standards for program directors and preceptors. And it is felt, and we know that will be able to be ascertained elsewhere within the standards. And then we also deleted standard 2.17 related to multi-site with the changes that I had just mentioned. Then when we transitioned to the KGOs, the PGY1 KGOs were harmonized and they were implemented in July of this year. And the crosswalk that Eric Gray spearheaded, and thank you for doing that, and everybody's hard work on the KGOs work group to harmonize and facilitate that crosswalk, and that was posted on the website. Looking forward to the PGY2 KGO revision, the updates are in progress. The goal is to have a core templated KGO structure with language to align with the PGY1 harmonized KGOs. This will hopefully create efficiency in the PGY2 KGO revision process. And where the PGY2 programs will differ will be in the customization of their appendices. The development of 2 PGY2 KGOs templates are planned, one for direct patient care and one for indirect. The work group, again, has been started. We've been working diligently on Friday mornings for this past year, with anticipated implementation in just a few more short years. And then in parallel, a lot of accomplishments from Pharm Academic, our Pharm Academic partner, and many thanks to all those folks in Pharm Academic who have worked so hard. The electronic academic professional record that has come to fruition and supports less documentation that will be needed to be submitted prior to a survey. The professional engagement page, I must just call this out, the flags will be removed to align with the elimination of standards 4.3D and 4.6C. That will happen sometime in early 2025. And if you haven't had a chance to try this out for your program, the annual Residency Accreditation Report analytic dashboards are there for your viewing. And there's a lot of additional help documents. And the residence file tab has been updated and redesigned, and this allows for seamless uploading of the deliverables for your residents. Has a miscellaneous folder there for other resident-specific files. And going forward, this is going to support standard 2.15C and actually require less documentation that you have to submit when you're undergoing initial or reaccreditation. And future planning enhancements are ongoing, so please stay tuned. APR tracking and reviewing and all kinds of other goodies are coming down the pipe. And for some additional accomplishments, the pediatric specialty pathway status updates. If you recall, the first year was in 2023 and 24, and we now have 7 programs that have a pediatric programs with a critical care specialty recognition and 4 programs with the oncology specialty recognition. I'd like to especially thank Jennifer Hamner for her hard work and her spearheading the work group over these past several years to see this to reality. So thank you, Jennifer. And just where you think we're done yet, and we're not done yet, the PGY2 thrombosis hemostasis management demonstration update. Huge thank you to Carrie Pickworth and Jeff Huntress and their work groups and all their hard work for the past many years. There are now 11 total programs. 4 are accredited to date. The first program was accredited in March of this year. We have 4 programs in candidate status and 3 in pre-candidate. The Commission will continue to monitor all the programs and consider discontinuing the demonstration PGY2 terminology in 2028. So with that, please join me in just a round of applause to celebrate the successes of the Commission this year, and I want to say thank you. Now I'm going to turn it back over to Sam, who will dive into residency growth and capacity.
Thanks, Pat. So hopefully the commission hit some of the marks for you that we gave us last year. I think we got some positive feedback from folks about some of those changes, and I also want to thank all the individuals that were involved with the multi-site revision. That was a big one that, Julie walked in the door and I said, here, have this as the first thing to fix, and Julie stepped up, of course, and gathered the right folks, and I think we hit the mark with the new regulations. So I'm not going to spend too much time on data because all of this is out there, but just really quick, looking at our growth of residencies, we're still moving in the right direction, up and to the right, about 2,951 programs. I can't wait to hit that 3,000 mark, and I think we're going to do it. I think we have over 155 new applications in for this year for new residency programs. Majority are PGY2s. Yes, so majority are PGY2s. So, it goes in line with this graph where we're almost 50% PGY1, PGY2. So you could see from the distribution here. Just to give you an idea, 2023 we had 1501 PGY1s, so a gain of 16. 1264 PGY2s, 1291 this year. Combined PGY1 and 2 stayed the same. And then when you look at the distribution of PGY2 programs, this is the top 15 growth. I'm not sure why that green arrow is there, because I didn't put it there, but it's only on my screen. Okay, well, you don't see it. Do you see it? It's just on mine. Okay, so AmCare continues to lead the way in programs. There's no care like AmCare, right? So yeah, so I know those things. This kind of flipped by itself, so who knows? We're going to just go with it. So looking at applicants, so this is important to know as we hear the anecdotal note that applicant pool is decreasing. So what I did was bump up the applicant pool against the number of graduates. And we consistently get about 40 to 43% of the graduates, pharmacy graduates, to residency program applications. And that, again, continued in 2024. You can see how many PGY1 applicants we had, over 5,000, and then about 1,000 PGY2 applicants. And, I know these are small increases, but I think it's important to see this, that the number of positions offered and the number of applicants did increase, 0.4% for PGY1 in positions, 0.3% in applicants. But if you look at the previous year, we were down 7.6% of applicants in 2023. We did see also an uptick in that PGY2, 1.8% in positions offered, 2.2% in applicants were increased. We saw a 10% increase in early commits. So you could see where we've been over the years, 664 early commits last year. If you remember, one of the things we did was open that early commit to health systems. So you no longer have to just be in that hospital. If you're in a health system, you can early commit any of those hospitals within your system. Rules made up by you. You decide what you want to do with those early commits. Why did we do that? Just a reminder, it's trying to recruit for those difficult positions to fill, such as AmCare. That's one of the ones that we had some open positions last year. Informatics, the MUST programs. So all of those programs that are difficult to fill, how do you get to those PGY1s ahead of time and expose them to those critical areas that you have and can fill through your PGY1 program? Overall results, you can see there was over 5,800 positions in the match and how they fell out with all of those. 4,907 applicants matched. We did have 1,100 applicants unmatched. Now, that is after phase 2. We don't know right now how many of them got positions in the scramble. But I'm trying to come up with a way that we can find that information out. I have to talk to my friends at Pharm Academics, see if they can help me out. But we're working on that last piece to give you an idea of like how many went unmatched or didn't get a residency program. So those are the numbers. I think this is something that we continue to look at, this reasons for not completing programs. We did see, again, another uptick in resident was unable to become licensed within the policy time period. And the second largest section being withdrew for personal reasons. So both of those are interesting to me. I know I talked about it last year, as we need to dig deeper into each one of those to understand why. The become licensed, unable to become licensed, I'm working with NABP to see if we could come up with a research project on that to kind of get down to the nitty-gritty. Is it NAPLEX? Is it not getting your ATT in time? Is it the law exam? So all of those are factors which we don't know exactly why, but we're going to continue digging into that to try to understand. The second one is personal reasons, and we have the ASHP Foundation and University of Georgia are working together they came up with a survey where we're trying to find out if we could dig into some of those personal reasons. You all know when you fill out that survey, you just hit personal reasons, but they're not defined. Like, we don't have those broken down. Was it stress? Was it, some other reason? So we're trying to get a handle of that so we can give you some tools to help your residents so that they stay in programs rather than decide to leave those programs. So again, I didn't want to go over a ton of data today because you can find it online, because I really want to get to the questions. But I do want to, of course, show you the 2025 schedule that's happening as we speak. Here are the dates to remember. There won't be a quiz later, but these are the dates that are out there. So we did give an extra week between when Phase 2 opens and when you have to put in your Phase 2 rank list. I think that was asked last year. Give us a little bit more time so we can really vet out those candidates. So we'd give you an extra week in there for the ranking. So let's talk about the "We Heard You" section. I just have to go back to 2023 because I always worry about follow-through. To make sure you heard us, we have to go back and say, here's what you told us, here's what we did. So we kind of put this together. It doesn't answer every item, but it kind of gives you an idea of that we are following up on these items. CMS was an issue last year. We heard about the clawbacks, and on our website we went and we have a residency toolkit on there with best practices for PJY1 funding and CMS audits. And when we say best practices, understand this is crowdsourcing from individuals who have gone through audits. We're not getting any help from CMS, Don, saying here's what the best practice is. You all know that. So we're using the information we do have to give it to you so that you understand what other folks have done. And the offer still stands. If you ever get that audit in your house, let us know, and we hook you up with our government relations team who will work with you through that audit process. We are an advocate for a bipartisan legislation. You may have seen this in an email. I sent it out to a bunch of people. I think ASHP sent it out as well. It's part of the Rebuild America's Healthcare Schools Act of 2024, and it is to protect the critical federal funding as well as looking at PGY2 funding as well. So if you go to the website and you hit that Take Action button, it's a really great system if you haven't worked in. You put in your zip code, it tells you who your congressmen are, you hit send, and it goes off to the people with the pre-formed letter. You can edit that letter if you choose, but the more noise we make, the better on this topic. So if you have an opportunity to look at that, go ahead and do that. Annual program report in Farm Academic. That report that's of the dashboards that is available to you. We cut down that annual survey that just focused on those questions to hopefully make that administrative burden a little lighter for folks. Remember, that was something we talked about a lot last year. You're going to hear a little bit more once Julie gets up here about that and some of the things we're doing. So hopefully that has helped you with the survey process. Licensing, like I told you, we continue to partner with NABP and other organizations to try to figure out what we can do with that licensing. California did a nice survey in their state looking at this, and the one thing that came back is no one believes that extending the standard to more than 120 days is the answer. And I know that's something that we look at, and the commission we talked about it in the commission. It is a postgraduate residency, and it is, you want to be a licensed pharmacist and practice while you're in there. So I'm not sure moving the 120 days is the answer, but we will continue to look at that as we move forward. Recruitment, I know in case that comes up, I want to address it again. We have some helpful tools on our website, but the interview format is up to the program to decide. ASHP we're not going to put out a statement, it's better to do it virtual or in person. It is up to the organizations, again, to find the best group of candidates that you can find using what you feel is the best tool out there. The RPD focus group, if you've been in that advisor, I call it a focus group, but on my email it says advisory team. If you are on that group, thank you for answering my emails. I try not to be a pain by sending out too many, and if you're not on that, please just email me, I'll throw you on it. It's a way to ask questions to you. Are we hitting the mark? What should we be doing? The last thing I just put out, I was looking for speakers for the Futures meeting. If you don't know, there's going to be a full track of preceptor and RPD development at the Futures meeting. It is going to be the preceptor conference within a conference, so we're moving it to live. We had a lot of interest in having the preceptor conference live, so we're folding it into the summer meeting. So more to come on that, but if you received that email, I'd love to hear from you. They're curated sessions, so it's meant to address the issues that you want to deal with and being more of a workshop style where it's hands-on working on things within the conference. If you were at Pharm Academic, development plan was moved into an electronic form within Pharm Academic, but we also listened to you wanted some more positive examples on our website. Apparently the one we had on there was a little negative. It came across that way, but I think it was just an example of one out there, so we put some more examples out there for you. All right, so I got some grief about the forecast letter of recommendation last year. We did do a survey. I will tell you that the survey revealed that there's a certain group that loves writing letters of recommendation, and then there's a bigger group that does not love receiving letters of recommendation. So what we decided is to, again, make that an optional for the application, but we did reinstate the comment boxes in the characteristics evaluated section of the reference form that was asked of you, and liaison was nice enough to move things around and put those back in with a little begging. So we have those back in place, so I'm thrilled to there. We did ask to have an optional, you can share your pronouns, that has been added. The reference reuse functionality, there's some more user-friendly directions for you so you understand how to use that reuse button. And again, reference letters are not required unless the applicant is applying to a program that requires that letter. So we're telling the applicants to make sure they look at what you require, and if it is one, then to make sure those letters are updated or uploaded. With that, I want to bring Julie up to give you some news about survey transformation and that reducing the administrative burden.
All right, well, thank you, Sam. Thank you, panel. And thank you, all of you, because I joined ASHP in April of this year. It has been an incredible honor to work with this team and to work with all the surveyors and to work with the commission and to work with all of you, and I'm really excited about that. So I get to share some really exciting information too about surveys and some of the things that we're doing a little bit differently. Again, a lot of this is based on feedback that you provided us, so thank you so much for all of your engagement in the process and for giving us some suggestions and things to work on. So when I got to ASHP, we worked on multi-site, we worked on some survey transformation, we've got tackling a lot of great things. Okay, so I'm excited to share some of the pieces that we've worked on from that standpoint, and some of it is ongoing. It's a bit of an iterative process. But one of the really big things that we're looking at is that pre-survey preparation, the pre-survey packet. If you undergo a survey, you know that packet asks for a lot of information and can sometimes result in PDFs that are, 1,000 pages long, those kinds of things like that. So we're really taking a critical look at what we're asking for programs to submit in advance from a survey standpoint. There's a couple more pieces that I'll talk about with that, but really taking a deep dive into evaluating that. We've already scaled back some of those pieces, and there's some efforts to scale back some more. So if you were surveyed like 2 years ago, you did have to submit a really long packet. If you were surveyed more recently, it's a shorter packet, and it'll become more streamlined from that standpoint. From the survey itself, also some adjustments to how the survey is structured in terms of the agenda for the survey. One of the things that we worked on from a survey standpoint is to eliminate that initial session with the C-suite and bring it down to one meeting that the survey team has with the C-suite, really now just to wrap up the survey as opposed to having to have 2 meetings with the C-suite. And I know from being in RPD, sometimes trying to get time on calendars of the C-suite folks is a challenge in and of itself, so trying to streamline that from that standpoint. We also made some changes to the survey report. We heard feedback from a lot of you to say sometimes the survey report is a little confusing, and while the consultative recommendations are really helpful for programs, sometimes it becomes a bit confusing. What do I have to respond to? What do I don't have to respond to? What is a helpful suggestion? And really trying to make sure that those pieces are a bit more clear. So if you're surveyed and you receive your survey report now, you'll see that those consultative recommendations, while still provided during the course of the survey, no longer appear on your formal survey report. Other exciting changes, Pharm Academic. You've heard in a lot of sessions and some of the slides here, some of the exciting enhancements that have been made and really moving towards that ultimate goal of using Pharm Academic as the source of truth from a residency training standpoint. Information that's available in Pharm Academic no longer needs to be printed off and submitted separately in the pre-survey packet, which is huge and really exciting for folks. We talked a little bit about, I know there's a lot of excitement about things like the electronic APR now being available in Pharm Academic. The enhancements that I think Pat talked about the residence file tab for deliverables in Pharm Academic, all of those things that are available in Pharm Academic, if they're utilized in programs, and that is another way that you can reduce the administrative burden of having to print off things and send it from a survey standpoint, but really also just to streamline your day-to-day management of residency training too. So we've really been trying to work on strategies to further decrease some of those components that we know impact program management. Again, similar to the pre-survey packet, when you're responding to a survey report, if the information is in Pharm Academic, you used to have to print off things like examples of learning experience descriptions or examples of feedback or those kinds of things like that. Now, if the information is in Pharm Academic, you no longer need to print it off and submit it with your survey response. So the lead surveyor will have access to Pharm Academic to review that evidence directly. We will say try to leave us some breadcrumbs though, so we know what we're supposed to be looking for when you submit your survey response. But I know from having to print off pages and trying to take screenshots and things like that, sometimes it wasn't really all that user-friendly. And if the information is accessible in Pharm Academic, our surveyors will be able to access that. Also, we anticipate there's a huge impact of eliminating standard 4.3.D and 4.6C. So hopefully that is something that is wildly exciting for folks, but it really does simplify the preceptor appointment and reappointment process. That was really the component of preceptor qualifications that tended to be a struggle for most programs and most preceptors. And so by eliminating that particular standard, the thought is that there's probably going to be fewer individual preceptor development plans that need to be developed by RPDs and preceptors and those kinds of things. So anticipate that there is an impact to that decision as well in terms of that administrative burden. Pat talked about some of the changes to the regulations in terms of RPD changes and really kind of making that match up. If you do have a change in an RPD, previously you submitted the new RPD's APR and their CV. The CV is no longer required, so it's just the APR from that standpoint. So really trying to hone in on the information that is specifically needed and try to keep that in mind. So that's just a couple of the pieces of the things that we are working on, have worked on, have implemented, are in the process of implementing. So I would expect a year from now we'll have even more updates for you. So very exciting. All right, so this is the new section, the Did You Know section. And I know nobody knows this slide because nobody knows. This is the first time that we are announcing this. So did you know? No, you did not know this until now. We are forming a new veterinary pharmacy residency task force, and this is really related to some interest within pharmacists that work in this area and have some non-human patients, and looking at residency training in that space, and really trying to get a sense for what that looks like, really looking at what the needs are, looking at our standard accreditation processes, those kinds of things. So I am really excited to announce that we are forming a task force to examine all of this in veterinary pharmacy. Thank you to Michelle McCarthy. Many of you know her as the lead surveyor. She's also the task force lead. So we are looking for participants, specifically if you practice in this area. I know lots of us are really interested in this, and this is near and dear to a lot of our hearts, but we are looking for a couple of folks to serve on this task force. We want to keep it small. We want to keep it manageable, probably 10 to 15-ish, if I had to guess, in terms of number of folks. But to really take a deep dive into this issue and provide some recommendations to the commission from that standpoint. So if you have completed residency training in the area of veterinary pharmacy or you're currently practicing in that area, you're involved in residency training and considering opportunities to train residents in your practice, we are looking for you if you're interested in joining this task force. So how do you do that? Just send a note to either Sam or myself, and we'll get you hooked into that task force. We're looking to get it started pretty quickly, so likely the kickoff meeting is going to occur in January. But if you do practice in this space, and this sounds like something that you're interested in, or if you know somebody who practices in this space who isn't here in this room, please have them get in touch with Sam and or myself. So very exciting. So you did not know, but now you know. Very exciting. Okay, other things in terms of the Did You Know section. We also have had a residency program director mentoring program. This program began in 2022 with a couple of exciting goals that are listed on the slide, but ultimately matches are made based on program and organization type when possible, and it's really designed to help some of those newer RPDs kind of connect up with maybe a seasoned RPD or be able to exchange information, ideas, those kinds of things like that. So we've had a couple of past cohorts in 2022 and 2023, and then 2023, 2024. You can see we matched 459 mentees with 277 mentors. So some really good interest in this. We did have a call for the current cohort that is being matched now for 2024, 2025. If you missed that cohort, there'll be another call probably in about 9-ish or so months from now. But if you are a mentor or a mentee in any of the cohorts, please note that we also have a meet and greet. So take a look at that. It's in your ASHP Live app, but it is tomorrow on Monday, December 9th from 4:30 to 5:30 with the information in the app. Also, wanted to draw your attention to pharmacy technician education and training. There is a phenomenal toolkit out on the website if you haven't had a chance to take a look at it. Many thanks to all the folks that really work hard on that. There's a toolkit for how to start a pharmacy technician education and training program and an FAQ document. If this is something that is of interest in your space, please take a look at that just as a helpful hint. This makes a really, really good PGY2 HSPL project. So if you're looking for something that aligns maybe with your strategic plan, there's some resources. And I know Lisa is also a really great resource for all of this as well. Okay, the ASHP Foundation Visiting Leaders Program. Maybe just by a quick show of hands, has anyone participated in the Visiting Leaders Program? Yeah, a couple of hands. I know we did in my organization when I was in RPD several times. This is an incredible experience. If you haven't had a chance or did not know about this opportunity, please take a look at it. There's some information out on the website, on the ASHP Foundation website, because we partner with the ASHP Foundation. They will be accepting new applications for spring visits from a leader within pharmacy. You can apply to have somebody come to your site and work with your programs and provide some really engaging discussion and leadership topics. And it's a really great preceptor development. It's really great for your residents. It's just a really unique opportunity and a really, really cool thing. So the date for the new applications is January 2nd. So take a look at that. Okay, and then this last did you know, now you know, because Sam talked about this in his section, ASHP Pharmacy Futures 2025. We are really excited to have some specific RPD and preceptor specific programming integrated and infused into Pharmacy Futures 2025. So take a look at that and consider joining us in June in Charlotte, North Carolina for that excitement. And with that, I don't know, is that all the did you knows or did you have another did you know?
That's all it is.
All right. So with that concludes all of the slides that we have, and I know everyone's really excited to get to the Q&A portion. So I will turn it back over to Sam, but thank you, everyone.
All right. So the time has come for us to stop talking at you and for you to use the mics and ask some questions. Just so while you're all getting up to the mic, which is one there and one there, two things that I want to bring up that we did not forget is one is the cost of applications, the student cost behind that. We touched on that last year. We're still looking, we have to look at contracts for that. So know that that's still something that is on our radar as we're moving forward. Is my friend John Armistead here? Yeah. Okay. So mid-evaluation, going to final, it's still on the path. So in case I save you a trip to the mic, you guys. All right. Questions? Thank you. You're all set.
Hi, good afternoon. Paul Nowierski, Director of Pharmacy at Lenox Hill Hospital in New York City, part of Northwell Health in New York, 23 hospitals, about 10, 11 residency programs. We invited Sam and his group to come to New York and visit with us last year when we were here. There was a lot of discussions about things that they could do, and I just want to say they came, they sat, they listened. I think they've done a lot of great things in this past year that have made things a little bit easier for us. They got a way to go, but at least the channels have been opened, and our organization was very happy and very gracious to have them in our organization and sit down for several hours going over all the issues that he's brought up today and some that he hasn't brought up but are still on everyone's mind. So I'd just like to, I said I would come and say thank you, and so I came to say thank you, Sam.
Thank you. Yeah. So last year, if you remember, I invited, like, hey, invite us into your shop, and I would love to come and listen to, your issues, have some discussions on where we're going. And he was the first one to come up and say, hey, come to our shop. Now, I went in November. I got it in before the wire, before December, but I got there. And it is great to sit down with teams, not related to the survey, sitting with you and saying, tell me what's going on and, what's working and what's not working and what could we do to make your lives easier. So going to health systems was fantastic. I've done a couple of them, but I've also started doing state meetings. So I was able to do PA state meeting as my first and did a town hall there. Got to meet some great RPDs and listen to what's impacting them and what's getting in their way from training. And Arizona just invited me as well. So if you have if you want us to come visit, we would love to do that and speak with your preceptors, RPDs, and really bring that back to this team and to the COC so they can hear your voice in the room where we're making decisions. Thank you for hosting us in New York. It was a phenomenal visit. Yes, sir.
Hi, I'm Alan Duval from Kern Medical in California. We just went through our accreditation cycle, and there was just a couple things I wanted to mention that might make it easier for other people. When we got our list of citations formally, like in the paperwork, it was split up between like a Word document table and then also an Excel spreadsheet table that like part of the information was in the Word document, part of it was in the Excel spreadsheet, and it was just cumbersome to go back and forth. We ended up having to combine them on our own to keep it all together. If we could get that just in one document going forward, I think it would be super helpful. Something else that we weren't aware of, I guess because it wasn't clear, the timing we have to submit the updates on our citations, the 60 days, we thought that was from when we got the official formal paperwork for it. But once we got that, we were told, no, the 60-day timer starts from the on-site visit. So we ended up only having like half the time we expected, which that's probably on us, but it might need to be made more clear during the visits that we need to start working on this stuff as soon as they leave. And then the last thing was we actually didn't get one of our PGY2 program got deferred because our resident had a delay due to health reasons and hadn't graduated, and we didn't even know that was a possibility that could have happened. And when they were on site, they knew our resident wasn't there. It would have been helpful for them to tell us that while they were there instead of just getting kind of caught by surprise in August that we didn't get a decision yet.
Okay, thank you so much for bringing that up. I'll address a couple of things. In terms of your first points, we'll take a look at that. Typically, your survey report is just one document, so maybe that's something that we can connect up offline and just kind of see so that we can make sure that that doesn't happen again from the future standpoint. But typically, the survey report should come in just one document. In terms of the timing, it is 75 days from the last day of your survey, and that's when typically the report is due. So we can talk amongst ourselves to make sure that that's really clear and make sure that that's something that is clear from your standpoint too. The last piece related to, I think you're referring to a program that is a new program. And so looking at the regulations, and honestly, this is something that I don't know that I even realized that until I really dove into the regulations. Our regulations do say that we can't accredit, or the COC cannot accredit a residency program if they haven't had at least one resident graduate from the residency program. And so from that standpoint, I think when we have a resident who hasn't completed the program by the time the COC meets, the COC can't, by regulation, make a decision on that. So then we defer that to the next COC meeting, so that's when that decision will be made. So you don't have to submit any extra material or anything like that. It's just our regulations don't allow us to accredit a residency program until there is a resident that's completed the program. So that is something that could potentially happen, especially when we try to get out there for new programs, when we get out to your sites to survey your program within the first year of your residency. When you've got your first resident, sometimes we try to come as early as January in your first resident year. If something were to happen where that resident doesn't end up completing the residency program, we have to defer that from that standpoint. So
anyhow, I don't know if that addresses or if anyone else has anything to add to that. But thank you for bringing that up.
Thanks.
Hi, Jenny Potmisai. I'm from VA Central Iowa. Just a couple comments about taking boards. A lot of the things you mentioned are definitely things that are impacting our residents' ability to get licensed in time, but two things that I didn't hear that I just wanted to pass along that have definitely impacted us is just the ability to get the tests done. There's not enough test sites. Residents have to travel for hours to get there. And then over the past years, I've had not one, but now two residents who have taken a board exam. One was NAPLEX, one was law. The answers be completely lost, no score assigned, and then the board can't figure out how to waive the test or the waiting period. And as I talked with people, they said, oh, that's happened over here. So I don't know how often that comes up, but it's completely unacceptable that those scores are lost, but the resident still has to wait. So just a couple more things I wanted to pass along.
No, I appreciate that. Appreciate that. Yes, sir.
Good afternoon, folks. Julie, you forgot to ask how many people in the room are cranky old men who can never give up griping. So I want to start with, there was some very encouraging things I actually heard here today. Some things that were important that were said last year and got addressed. I remain personally dismayed by the number of people that think a formal recommendation, letter of recommendation, has some direct connection to a person's capacity to practice pharmacy, but I mean, we all have our issues. I'm about to get into my one, I think. I have a couple of actual questions, but a comment and a little bit of history. I apologize to everybody in the audience. I tend to rant. I'm not going to rant. I'm just going to speak calmly for a change. I was a resident in 1984. And at that time, and for at least the first 20 to 25 years of my life, if not 30, we had a couple of things going on. One, we had live, in-person, 3 times a year examination dates. Nothing computerized. The last Tuesday in June, the first or second something in August, and then a date in mid-December after the midyear. People were not licensed for that many number of years as residents for possibly 6 months of the residency program. Now, I've heard plenty of people tell me we need the 120 days, Frank. The 120 days is a minimum. There is nothing in educational research that says an amount of time in training guarantees a competency. Why don't we add another year of school to them if they are not competent by the time they get to us? I don't get that. And it undermines the value of the RPD's professional opinion of their competencies if it doesn't matter, because what matters more than anything else is they at least get that 120 days in. I'm sure it supplements it, but I don't understand it. I don't understand it at all, because we also are allowed to let RPD say they're so good that they can do an early commit in 6 months, which is December, which would be not the whole year, but certainly not, it just seems to be a modest disconnect there. I'm starting to talk too fast because I'm getting worked up. I'm going to calm down.
Deep breaths, yeah.
I can't do wellness. It's not my nature. So I think there should be there's some contradiction in how we're letting RPDs exert the value of their professional judgment about the trainees. And maybe we don't trust the RPDs. Maybe we don't trust the letter writers, which is why people don't want letter writers or something. I don't know. In my mind, there's plenty of reason not, because I hear way too many people say that it's my professional duty to support my school and my students and my residents to make sure they get a job, more than say it's my professional duty to say they got to be competent to go to that job. That's a disconnect that's out there and has been getting worse, an opinion. I don't know what you do, but I do think that to have people dismiss it is to not really think about how it appears. And it's not appearing just in my mind. There are people in small subreddits and Reddits that are talking about it. So I think it needs to at least be brought out into the open. On that note, thank you for adding conference time to the days off. That was horrifically dumb. We're thanking you. I'm not taking
I got it.
I didn't do anything. Well, I'm making sure.
You did. You brought it up last year, so. Yeah.
I don't need it. I never. Did I ever act like I wanted a boss's approval? So in that regard. But I think what's still missing, a couple things that I think that are still missing there, and I wish the commission would consider somehow putting it into either the actual standard, which I never really read, or into the guidance document. One would be a minimum number of days off. And if you want help with a specific number, tie it to the minimum number of days a brand new pharmacist working there gets. If they're being asked to work longer, harder, and more with changing what they do every month, they ought to get the same damn benefits that the regular pharmacists do. And I'm aware of programs that give them less. And the last one, please somewhere put some specific guidance down for PGY 1 directors to know what they should let PGY 2 directors dictate as to the start date or the end date of the residency programs. Not some, oh, you guys want to abuse them faster. All right. Bless you for bringing live preceptors conference back. I'm already going around informally mentoring programs by just popping into where I train people and say, I'm talking to you for half a day today, whether they want it or not. I've gotten a couple lunches out of it. I guess there's some value being perceived. But I think trust I will be in Charlotte.
Yay.
I can't wait.
I mean,
and when it comes to the mentoring RPDs, I don't know what you're using as quality, but I was retired. I have a lot of free time, and while you should fear I will teach them how to get away with training residents by not following all the rules, I still think that I can help with that if you want.
No, I appreciate that. Thank you. So, you know, I want to touch on the 120 days because I think it is a hard question to, or a problem to solve. And like I said, it didn't go off the table. We're still trying to figure it out, but I need some more data to really understand, why aren't folks passing in that time period? So I don't think it's off the table. I think we're still wrestling with it, and we'll still work on it until we get that answer. What's the right thing to do? So I appreciate you bringing it up. By the way, Eric is typing. He's taking notes, writing down your questions so that we can publish them again like we did last year. And then you can hold me accountable to respond to any of those next year when I'm up at this, well, not this one, but one of the podiums, hopefully a smaller room. I don't know, we'll see. Yes, ma'am.
Hi, I'm Anna Benson from the University of Minnesota, and I am happy about the removal of the 4.3D and 4.6D. But in the email that got sent out, there was a comment about programs may opt to retain ongoing professional engagement requirements for appointment reappointment. Will this be at all surveyed, or is this truly an internal component that the program can put together for their preceptors?
You mean it'll stay on the APR and it's optional? Yeah, we will not be surveying that. That is for you to do what you think is right for your facility if you want to use it. The red flags are still showing, as Pat had said, but by Q2 of next year, the flags will be gone in the APRs, but they'll still be there for you to use it for your internal.
The APR form will not be changing.
The APR form will not change. By the way, and we're at about 50% of RPDs, is that what it was? Using the electronic APR, yeah? Preceptors using the electronic APR. Our goal is to make that the way that we put APRs in. We would love to get rid of the paper. And if you put things within Farm Academic, you don't have to put it in your packets when you're surveyed. So as we say, it's optional now. We may be moving as that gets over the 50% point to say that is the way we would like to do APRs where possible. Yes.
Hi, Sam. I'm Richard Dang, University of Southern California. Much like everyone said, thank you to you and the commission staff for making so many changes. I know I sent a lot of feedback last year, and I see a lot of positive changes made in that direction. On the topic of difficulty with licensure examination, I know many programs, including ours, have been grappling with that issue now for many years, and it has just exploded over the last few years. I worked with CPHA to develop that survey, so I'm glad you got a copy of those results.
Yes.
But from what we're seeing from our program, it is largely the licensing exam. It's not so much NAPLEX. It is largely the state licensing exam, and this issue may somewhat be unique to California, but also I know it's not because it's nationwide. In California, the difficulty is we only offer the exam once a month. And there are no dates that are available, that are regularly offered. So when a resident fails a test in, let's say, July, they don't get their results until the next month in August, but they have to wait 45 days for an ATT. By the time they get their ATT, all the dates are filled for September. Then they have to take the October test. And then when they failed that exam, they're out of luck, and we have to dismiss them because it's past the December deadline. They can't take a test until December or January, and that's just too late for us to wait for a resident to be licensed. So at least in California, the issue is the lack of available testing dates that are being offered to licensees, and the vast majority of our residents are not getting their ATTs until late June, early July, and that is way too late for a residency program. Once the residency starts, it is hard for residents to study and devote their time to their residency training, and it's even worse for out-of-state graduates. And if we're trying to increase diversity of out-of-state applicants and candidates to our programs, we're not really incentivized to do that if they don't receive their ATT in time merely because they're out of state. So those are some issues that maybe you can take back to NABP and figure out to help us resolve. Thank you.
Thank you. I appreciate that information. And again, the collaboration and communication with NABP is there, and we're certainly going to bring that feedback back to them and see what we can do to try to shed light onto not just the ATT, but the number of sites, because I hear that a lot as I communicate with folks across the country. Yes, sir.
Hey, good afternoon. Adam Gregg, Amplify Health, Gunderson Region, Program Director for our PGY1. Again, I just want to echo the appreciation for the responsiveness and evidence of change over the last year based on feedback. I'm going to riff a little. Julie, I can't remember, you said survey reform. I don't think that was the right...
transformation.
Transformation. That sounds much more positive. Consider this a consultative recommendation then.
Eric, don't write it down. Don't write it down.
I guess in thinking about not just the front end going into the survey, but the back end, I guess I would ask if there's been consideration at any point for having a more defined or transparent rubric or some other guidance in terms of what that outcome of a term of reaccreditation or would be coming out of that survey, recognizing, of course, that is evaluated and determined by the Commission and Credentialing. I guess just a little context, we had the fortune or perhaps misfortune of being one of the early programs that was surveyed after the implementation of the new standard last year. And going in knew that there were several things that we were in progress and working toward. So the results of the survey at the time were not necessarily surprising. What was surprising was the outcome of the determination from the COC. Frankly, it was a lot harsher than I think any of us were expecting, or got the impression coming out of the survey. I have to be honest, it was demoralizing. It made my staff feel less than. It made me as a program director feel like a failure. And to feel that way after being in this position for 18 years and having a lot of residents that have gone on that I'm very proud of as clinicians, I accept that for every program, there are things that we always need to work on, but it felt very punitive. So I'm not challenging the decision, but I guess I come back to, I feel at least if we would have come out of the survey having some sense, based on this is likely what the outcome is going to be, it would have helped us reconcile things a little bit more. Because, I have to say again, in a practice environment where it's becoming increasingly challenging to work with learners, and there's less intrinsic reward at times because we're having to fill in a lot of the gaps, this is just one more thing that was very tough to deal with. So thank you for listening. Appreciate all the work that you do and everybody in this room does to transform our profession. Thank you.
You want to comment on anything? Thank you. Appreciate the feedback.
Hi, Deanne Hall from the University of Pittsburgh Medical Center. First, I just wanted to start with a thank you. I was at the PSHP town hall, and it was great to have that in an informal setting and be able to talk with you on topics, as well as having program directors from across the state get together and get to see our colleagues that we don't get to talk to all the time. So I just wanted to say thank you for that. This is more of a food for thought. In recruitment, so I'm our PGY2 ambulatory care program director. As you mentioned, ambulatory care is one of the areas where we're starting to see, I think, my humble opinion anyways, that I think we're starting to see more programs than candidates, so it is getting more competitive. And how can we better reach out to those potential candidates? PPS has been a long-standing place where we've done a lot of PGY2 interviews, but we're starting to see that go down over time as well. A lot of it, or at least in our neck of the woods, is the financial crunches on institutions and allowing PGY2 residents to travel for meetings, as well as in our institution this year just decided we weren't going to do PPS for residency. So that leaves us with a showcase. Attended the showcase for many, many years. We get mostly the P4s that are interested in those PGY2s later, but we don't get a lot of PGY1s coming to us actively seeking positions because they're, if you think about it, they're at their showcases, right, repping their programs. So my food for thought is for the commission to think of, are there things that perhaps can be done to help target specifically for PGY2s, either virtual showcases or something like that, to help allow the programs to get the word out and be able to improve our recruiting efforts.
Appreciate that. And ASHP as a whole is looking at PPS and the future direction of recruitment. So there might be some changes coming about with that, who's the individuals who are in charge of that. But it's something we can take back to talk about how do we get more communication out there for those residency programs that are out there and how they could connect with all of you that have those programs available. So I appreciate the food for thought. Yes, sir.
Hi, Taylor Miller, PGY1 RPD at UPMC Mercy in Pittsburgh. Like others, I just want to applaud and just express my appreciation for the efforts in improving the survey and accreditation process. It almost makes me want to go through the process again, but almost.
I will pay you later. I'll pay you later.
Yeah. You can't afford me. My question and what I'm hoping to get some insight for, looking to the horizon as it pertains to Standard 5. That's an area both on the front end but on the back end when it comes to the administrative burden, responding to and providing comments on elements as it relates to that. In my opinion, it feels that if TJC or other accrediting bodies are okay with the site and the practice, that should be indicative of the quality that exists there. And so can you comment on ways or efforts that might be ongoing to streamline that, simplify it, and kind of ease that part of the accreditation survey?
Yes. Do you want to take that?
Thank you for that suggestion and for that segue to sort of talk about how that evolves into some of the additional things that we're doing from a survey transformation standpoint. From a pre-survey packet, we really decreased a lot of the emphasis and no longer ask for all of those policies and all of those kinds of things. And I think the survey transformation process is really moving more towards the resident and how the resident is integrated into the department. And from that standpoint, what are the department's strengths? How's the resident involved in those kinds of things? to really try to marry those two together. I don't know if that really directly answers your question, or if it's really more just context to say how we're viewing Standard 5 as it relates to the entire survey process.
I think it partially does, yeah. It just, I guess, along the lines of those consultative reviews or suggestions, it does add a lot to, we have to prepare for and respond to. I think we caught the tail end right before some of the Standard 5 revisions were made. And so we were creating policies that didn't exist, which took hours of, just meeting together and building something that we hoped would meet with the surveyors and in a way that they would find favorable. And then, at the end of the day, it didn't necessarily reflect or change the practice and kind of what we did for patients, for residents, or within the institution as a whole.
No, I appreciate that. And there really has been some work to streamline that, and work continuing. So thank you for bringing that up.
Thank you. Appreciate it.
Yes.
Hi. Thank you all also for always having this session and being open to our Q&A. I find it extremely helpful. And being up here, being pretty nervous, thank you to everybody who has already spoken and asked their questions. It's, I think, helpful to all RPDs. I have two questions for you guys today that are pretty different. The first is, first, I'm Liz Morrow from Dartmouth Health. We're in a rural section of New Hampshire. Give a little background. And this was my first year. I had a resident resign. I have 2 residents every year in my PGY1 program. And the reason for the resignation wasn't because of not passing boards, guys, not because they weren't clinically competent. I mean, this was a good resident. This person left because they got offered a job at another academic medical center, and they left before 6 months. And so I do a good job upholding my contract. Like, I have a contract with them that they matched with me. It outranked other program candidates that came and interviewed with us that we really liked. But being 4 months into the year, there's no way I can go back to those folks. I just want to know, like, what do we do? What can you do to support us when we have the resident break the contract? So that's my first question. My second question has to do with a Reddit post that I saw recently, and I kind of hope the rest of you saw this because it was interesting. And whoever responded to this candidate did an excellent job, but they were asking, how should I evaluate a program that has had RPD turnover? And there was one respondent, and they talked about everything the people in this room do. How much we work, right? How much we put into our programs, how much ASHP puts into our programs, but also requires of us as RPDs. And it was a great explanation to the student, and then there were still responses under it that said, red flag. That means there isn't program leadership. Ton of turnover, that doesn't look good. And I just want to know, do we ever look at that? Like, do we ever look at the RPD turnover for programs? What is the normal tenure of an RPD? And when things like this happen, like a resident resigning even though you're working your butt off and you liked them, how do we support our RPDs?
Well, I appreciate that. Let me just address that last piece. The whole reason we started looking at survey transformation and reducing the administrative burden is because we saw the revolving door of RPDs, and we're like, what is going on? And then we start listening to the burden of it all. So, I think that is one of the main reasons that Julie's doing what she's doing with transformations. Like, how do we make it easier? How do we, without decreasing the quality of programs. So I always have to clarify that, because I don't want anybody to think that I don't want quality program. We want quality programs, but how do we do it in a less onerous way? And I think that's what I take coming from a health system. I know the work that you do every day. And the last thing you want to do is put a 1,000-page ream of paper to send to us. So we're working on that, and that's really what we do see the RPD turnover, and we want to stifle that as much as we can. It's interesting that, because I sneak on Reddit every once in a while to see some of those wonderful comments, and this is coming from if it's a younger generation who don't stay in jobs long, right? So you all have applications now with folks who are every 2 years they're getting a different job. And when I started as a leader and interviewing people, that would be the red flag, right? 2 years, job hopper. I'm not looking at this application, but now that's the pipeline. Like, we need to know that everything's transportable, right? So there's no more pensions that lock you in somewhere. It's a 401k that you take with you, right? So we know that happens, and I don't know if I can respond to every Reddit troll that wants to say, red flag, don't do it. I mean, it's up to us to educate folks to say it does take a village, and maybe it's an RPD that does it for a couple years but then trains someone else to do it. You know, we have to be that spokesperson for, you know, the other side, if you will, or the counter argument, because there'll always be that individual. And if they don't select a program because of that one aspect, then they're missing out on something, would be my I guess, message to them.
No, thank you. And I want to shout out too, there was a really great ASHP article recently, and it was some program, I think in Utah, but they did this whole revamp based on a Reddit response that they saw. And one of it was actually to identify that we should have regular RPD turnover to keep programs innovative. And I thought that was an interesting take too.
Yeah.
I don't think there's a wrong answer there.
Yeah. Oh. And the first part of hers was? Oh, the student that left. So yeah, so I think we deal with that all the time as well. I'm not sure how you hold them to this contract, right? So the contract, if you break it, it says you could never apply for a residency again, right? That's all we can, right? That year or ever. We don't even honor it, so it doesn't make a difference. So, I mean, but those are the things we deal with all the time. Even in employing folks, you bring someone on, you spend so much time orienting them, they stay for a year, and then, you know, they find something different. It's the name of the game, and you know, we're seeing residents kind of uptake that now and move things along. I will say, all of you that have students, please tell them, if they go the fellowship route, to still take the boards. There's this upswing of folks going into fellowships and say, I don't need to take the boards because I don't need it for what I'm going into. And you know, you're never more prepared than when you walk out of that school. And if you wait a year or two, it's going to be more challenging for you. So that's another, you know, to do if you can when you go back and work with students. And I want to mention that fellowship because I know that comes up a lot. Like, oh, the fellowships are taking away, you know, resident candidates. And what I will say, when you look at that 40%, I don't think they're taking resident candidates. That's not my concern because I think students, if they're going to choose a fellowship, they didn't want to do a residency to begin with anyhow. So, you know, and maybe some of them did. I'm more concerned about, you know, the industry taking your seasoned folks away than I am about the folks going into fellowships. But, you know, you'll see there are fellowships here recruiting. Know that we're an organization of many different members, and we have to give students the opportunity to see the whole picture, right? And pick a path that makes sense for them. And if it's a residency, it's a residency. And if it's a fellowship, it's a fellowship. Because I doubt you want a resident in your program that really wanted to do a fellowship, right? It's just, again, a more of a time drain for you. So I just wanted to address the fellowship piece. But please tell students to take the boards and not skip them because of a fellowship. Yes.
Hi, my name is Lisa Sagardia. I'm a program coordinator for Emory St. Joseph's in Atlanta, Georgia. Kind of new in this role, less than 6 months being a coordinator. One of the things that I saw, this is my first time being in one of these sessions, the statistic with the number of residents that end up not completing the program, and that 23% being for, you know, personal reasons. I don't know if that's normal, but to me that seems really high. Right, and I know I'm also a part of SECM. We focus a lot on burnout. I know there's a toolkit for ASHP, but, you know, long story short, what I want to know is, what are you guys doing for programs in terms of support when it comes to residents having mental health issues, anxiety, depression, outside of that toolkit with such a high number as 23%? I imagine that has to do a lot maybe with mental health, not sure.
So that's exactly the reason we want to dig deeper, and that's why we're working with University of Georgia on that, to really understand, can we break apart what that personal reason is, because that's from the survey that you all fill out, right? Did you have a resident leave and why? And you say personal reasons. I don't know what that is. And at first I thought it was, well, maybe they have a family issue, but that's actually a different segment of the pie. So we have to dig deeper before we try to create a solution. And that's hard for a leader, like a manager like me. Like, I just want to solve the problem. Like, tell me what the problem is, let me solve it. But until we get the data, I don't want to do a knee-jerk reaction and try to solve something. So we are working on digging deeper. And the reason why is because I want to give you tools that you can use for your residents that are in those positions. So, give us a little more time as we dig into that. And I'm hoping by next year, again, we have a solution that we can talk about when we're up here.
I appreciate you. Thanks.
Yeah. Yes, sir.
Hello, my name is William, RPD, and I would like to also echo the great job you are all doing, and I would like to ask my colleagues to join me to give you another big clap. In fact, you guys are doing a great job, but as I sat here listening to everybody, I was very saddened by one of my colleagues who did allude to the fact that he felt like a failure after his residency survey. And that saddened me a lot, because one of the things I've realized that is, I think we need to reconsider the way we do the survey. I think it's too cut and dry in terms of check, check, check. My consultative recommendation to you is that could you consider looking at program innovations, which programs are being innovative in their design and in the conduct of the program, so that you could also bring those things out. You can go to a program, maybe they didn't check everything, but they have something so unique that they can share with others. And I think that will help also improve the joy with which the RPDs are doing the program. I think they are working so hard. I can tell you that every RPD here is working so hard. But sometimes, yes, you feel like, you're a failure. And I don't want anybody to feel a failure. Please consider innovations as well. Thank you.
Any comments on it? So we're with you, right? We want this to be a collaborative process that's quality improvement, that we're working together. We don't want anyone to walk away feeling like that. And I think that's another part of transformation. How do we go in as collaborative partners? And these guys in the front row here, they work hard to make sure they do that. And it's a balance, right, of making sure here are the things you need to work on and here are the things that you do great. But we need to, you're absolutely correct, we need to figure out a way that it is seen as a collaborative process and that no one walks away saying, I feel like a failure. So I appreciate the comments, and we definitely hear you and are building that into the change of how we're going to survey moving forward. So thank you. Yes, ma'am.
Hi, Sharia Bourdet. I'm with the Department of VA and preceptor and past RPD at San Francisco VA. I wanted to provide just a bit of a counterpoint to the discussion about the fellowships and increasing interest. In discussions actually with some students, many times that interest is because licensure isn't the barrier. Not that they're never going to take it, but they don't have to do it 120 days, that they have 2 years. And they choose that path because they still see it supporting their longer term goals of professional development. And it's a choice between residency and fellowship, and sometimes their mental health and their concern about being either terminated or having to resign from a residency program. So I really do think that is important in a consideration, and when we think about the 120 days. I also kind of want to find out too, just consideration, where are the other stakeholders in some of the licensure discussion, and specifically the schools of pharmacy? They are training the students, and the residency directors and the preceptors are the ones that are doing a lot of the licensure coordination after the fact. And so I think a lot of that burden falls onto the residency programs who were not involved with the initial training of the student. Plus the fact that the students, I hope they have a voice in this process. they're taking out loans for $200,000 and not getting a return on investment.
Yep.
So
your first point, thank you for bringing that up. That actually makes me feel a little bit better if folks are just delaying a little bit, but they're still taking their boards, because anecdotally what we hear is they're not taking them at all. So, hey, if you're delaying it a year and you're going to take it, great. I just want to make sure they take it, at some point, and closer to when they graduate versus later as it gets more difficult as you go. So I do appreciate that thought process. And again, we're still looking at that 120 days and seeing what's the right, solution if we can find one. So I appreciate it.
Hello, I'm Leah. I have a question related to sites that have multiple programs, or it could be, a health organization that has multiple programs. But some of the administrative burden is we're seeing that, the program itself, it's in this little silo, and it's not really looked at as part of the bigger health system. So if we have sites that have multiple programs, if we start a new program, do we have to start from scratch, or can you guys know that we have other programs that have been surveyed recently, and you still need to do an on-site survey with all of this stuff that we've submitted to you all, a couple of years ago, and just provide you with anything that's been updated since then with this new program?
Maybe I can address that and see if my colleagues have anything to add to it. There definitely are a lot of things that we consider from that standpoint as it relates to, is this a program that, as you described, a new PGY2 program that is added to another site that has a number of other programs. So we look at when those sites were last surveyed, and if it was very recently, we ask for an abbreviated version, so really just focus in on that particular program. If it's about time for those programs to be surveyed again, then we try to get everyone sort of coordinated on the same schedule. So there's a lot of pieces that go into that decision, but I really appreciate the sort of end game on that, and making sure that, we do really try to think about that as we're arranging the survey from that standpoint. So thanks for bringing that up as an important piece, though.
And from the standpoint of additional programs, they're generally virtual. If it's an additional program that the others have been surveyed, as Julia mentioned recently, especially from the new ones that you're mentioning.
So, Kirsten Oler, PGY1 RPD at University of Illinois, Chicago. Last year at this forum, we talked a lot about the letters of intent, and again, I'll echo my appreciation for bringing back the comment boxes for the characteristics. I wanted to ask about the reuse function, because I think that still sounds like that's sending the same letter to all of the programs, and it used to be that we could reuse but edit, and I think that's a really important function to have, because as our colleague said, we shouldn't all be checkbox programs, and different programs have different opportunities, do different things well, and I think allowing letter writers to personalize and individualize their letters of recommendation to certain programs is really important, because I think it goes back to your question about why are people dropping out of residencies and not completing. And I think this point of it's a personal issue, I think I said this last year and I'll say it again, that's an easy cop-out way for the resident to tell you it's a personal issue, when it's really I didn't end up at the right program because I didn't know what I was getting into, and I took it because I was afraid I wasn't gonna match. And I think we need to do a better job recommending different candidates to different programs. We need to do a better job understanding what different programs have to offer and do well and maybe don't have the opportunities for, and we need to plug in our students to those programs so that they end up the right place, because all programs are not the same checkboxes, and any good program is not a good program for every candidate, and I think we need to work on those letters of recommendation more. And I would also appreciate to be able to turn off the option of getting a traditional letter of recommendation, because even though in big bold letters on my website I say don't send them, I get hundreds of them because of how the system works right now. So.
Yep. So here's our challenge. We have to try to make everybody happy, right? So there are people who don't want the letters. There are people who do want them. So if I shut them off completely, it's going to get half the members are going to be upset about it. So we have to ride this. How do we make it as the best case possible so that everyone is slightly happy? It's really difficult, and I'll ask Lisa to speak of it, because we continue to tweak it and make changes, and at some point we have to stop making changes and let it ride, because the more changes you make, the more confusing it gets, right? And so I hear what you're saying, and that when we had the survey, we did the survey right after forecast closed last year, and the feedback that we got was the letters of recommendation are not the thing. The comment boxes are what we're more interested in. So that's the reason we went in that direction. But Lisa, I don't know if you want to comment on historically everything that you've been dealing with recommendation letters.
Yeah, I think you covered it for the most part, and that's why we went back to that. And I think from your standpoint, if I'm capturing it correctly, you don't want the recommendations from your end. And I think what we did this year is, and they just left unfortunately, but I went to the forecast presentation for students, and the liaison representatives specifically said to the students, or those, we have other people there as well, make sure and let the recommendation writers know for a site that wants a recommendation, and if it's not one that wants a recommendation, they're not to write one. So if you're a site that doesn't want a recommendation, you won't be getting recommendations. And I think that's going to help you not get those recommendations. Is that answering part of your question?
Well, I think in theory that sounds good, but what happens is in the comment box they say see letter, because they have to write a letter for some programs and not others.
But they're not going to have the ability to do that, though. They shouldn't have the ability to do so.
Okay, hopefully.
I'm hoping. And hopefully, if so, we do a quality check each year to see what worked and what didn't. And I'm hoping with the boxes that they're going to have more characters in the boxes than they did last year. So hopefully that won't be an issue. I think we talked about that on Connect. And I went back to the folks at Liaison to get more characters. You were actually very helpful with that for me to be able to do that. So maybe you won't get letters that way. And if you do this year, it's one more step to our quality assurance checks for that, because as Sam had mentioned, we got the character boxes back. And we're working towards, hopefully we won't have letters for those that, like yours, that don't. But that's our goal, and that's what we're asking for, and we put that in the directions. So that's.
All right, thank you.
Thank you.
Well, hopefully the reuse can be edited.
Yeah.
That's another big one.
Thank you. Yes, sir.
Hi, thanks for taking my question. My name is Nick Shaka, PGY2 Ambulatory Care Residency Program Director for Community Health Network in Indianapolis, Indiana. Wanted to just acknowledge maybe the unsung heroes of residency programs, which is the residency program coordinators. I've been blessed enough. I have been our residency program director for 8 years in my program. 5 of those years were without a coordinator, and 3 have been with one. And it's just a previous resident that left and came back and was motivated and excited for the program and to give back. So as I was thinking about the questions on burnout, the other RPCs asking great questions, I was thinking about the ASHP guidelines on coordinators, and there's not really many out there. I think they're called designees, and a lot of times that they show up. But it helped me out tremendously, especially this last year. We were reaccredited, and my wife had a scheduled C-section on the day of the accreditation survey, so I could just take my parental leave and have my RPC step in seamlessly We got 8 years of accreditation. It was great. But without that extra help, and I'm sure it happens in other programs, I don't know what I would have done. You know, would I go to like a different exam room and like try to video in to ASHP? So anyways, just wanted to get your thoughts about maybe making stronger verbiage regarding residency program coordinators or things of that nature. Thank you.
I can address that from the standpoint of the standard, and again, really trying to be thoughtful of lots of different models out there. There are some programs that don't have coordinators, some that do, and really there's a lot of guidance in the standard, and particularly in the harmonized standard, we were really thoughtful of putting in a lot of things that could be delegated or used to somebody, and we called it a designee because in some cases, organizations might have the ability to provide an administrative assistant as opposed to a program coordinator or those kinds of things. So really trying to identify in the standard what is maintained to be an RPD only function and really widen what can be others to sort of help out from that standpoint. It may be a little bit of a challenge to try to put guidelines to say you have to have a program coordinator because there are lots of different models that work for lots of different folks, but really appreciate your point about how helpful that support is, and hopefully the standard really supports having support for the RPD more than it had in the past. So I don't know if anyone has anything to add to that.
Thank you.
Hi, my name is Emily Peel. I'm from Rutland Regional Medical Center in Rutland, Vermont. I wanted to thank you for sharing the data on residents not completing. The percentages were very helpful. I'm coming from a program that has lost multiple residents over the past few years. One of the things I just wanted to encourage you to do when you look into those personal reasons is evaluate the reliability of your sources of data. I know we go into that survey that is being filled out by residency program directors. We've had residents give us very professional, not bridge-burning reasons for their personal reason for leaving, and it's really tough to find out, you know, from other coworkers or colleagues, even from social media posts of the real reason why they departed. So, you know, I think that survey is really important in getting the RPD's perspective on the personal issue, but I think if there are other ways to assess the deep dive into that data, it would be really important so it's actionable, so we can actually do something about it.
Yeah, I definitely appreciate that. The survey is two parts. It is RPDs, but then it's also current residents, because we know that the residency class probably knows if someone was dismissed, and maybe they can give us a little bit more insight. We were thinking the same way, that the RPD may not know the real reason. So we're hoping we can get something from current residents if they know a resident that left, and what the reasons are.
Is there any reason why we can't go straight to the source and ask the former residents?
Well, so I thought about that, and here's my concern is that I don't want to rub salt in any wound, meaning ASHP contacting them and saying, hey, why didn't you complete your residency program? Because if it was marked as personal reasons, but it was actually not progressing, I don't really want to kind of open that wound up. The other thing is we won't know how to contact them, because what we have is their farm academic email address, which is the organization they left. So it'll be hard to reconcile that. But I think the bigger reason is I really don't want to open any wounds with individuals if they left the organization and it was either stressful or there were some mental health issues. So I'm being cautious about how we get that information, but still trying to dig and get it.
Thank you.
You're welcome.
Hey there, my name is Ryan Peterson. I'm a RPD for a new PGY1 program. We're in pre-candidate phase right now. Our program is going to be housed at 100% in the ambulatory care setting, but of course we can't label it as a PGY1 AM care residency, which obviously I think there's reasons that might make sense, but I think that there's also reasons that it does make it hard for us to kind of socialize exactly who we are and what type of a program we're offering. So I just want to share that feedback and see if there's any Mike's struggling. See if there's any discussion on allowing that to be visible, so that our residents, say at the showcase, or whenever, can understand the type of program that we're offering.
Andrea or Amy or Lisa, historically, the change, can we talk about how we arrived here?
Well, we arrived at that really back in the primary care days. Many of you may remember that. Frank, you may remember that. I think a lot of it was because there were PGY2 programs in primary care, ambulatory care, and when a program was a PGY1 program that was labeled as a focus in ambulatory care, it was confusing for programs, for applicants that were PGY1, looking at PGY1 or looking at PGY2 for the future to really discern what was the difference. You know, and if there were a lot of rotations in the PGY1, if it said focus in ambulatory care, why were they going to do a PGY2 or vice versa, and what was the real change in them? And I think that's one of the reasons we stepped away from that, because there were a variety of areas that wanted to do that. The main one was ambulatory care, and that was probably, I would imagine, 15 years ago when we still had primary care programs.
The one thing I would just want to say is that I think that some programs like ours are well set up to offer more of that really generalized type of experience, where a much larger organization may have opportunities for an AmCare pharmacist that we absolutely cannot offer. And so I do think that there's still a way that we can kind of groom a resident for then doing a PGY2.
And I think that, and I can see that they're just two separate issues. An opportunity would be to, in your description, expand upon that at the present time, and certainly in all of your promotional materials. And something we can look at maybe in the future. Is there anything with the new database in the directory and pulling words?
Yes. So with regards to how you promote and advertise your program with the directory listing as it currently is, there is a drop-down box for the actual practice setting area. We are in the process of looking at opportunities to enhance the directory, our database. There's a lot of pieces in motion on that right now. And so that is going to be something that we will look at making some searchable features based on type of practice setting as well. So we hope to have more to come on that in 2025.
Yeah, so just a teaser. We're obviously, technology is something that I embrace at my previous organization, and is something that we are definitely looking at here, which is to revamp the directory so that it is more user-friendly, it's searchable in many different ways, and it actually gives you a landing page for your organization. You know, if I had pie in the sky, it would be you could add your logo, videos, you know, descriptions, and it's something that really highlights your practice site. But it's in the works right now, so again, see me next December, and I'll tell you where we're at that, but we're actively working on it. Yes, ma'am.
Hi, thanks everybody for taking our questions. I'm Pamela Moore, RPD for the PGY2 program, Pain and Palliative Care at SUMA in Akron, Ohio. We recently had our accreditation survey, reaccreditation survey for our 3 programs. We have a question regarding perhaps opportunity for the commission to offer a survey to the sites after the fact to give feedback. We have some questions about specifically, as all 3 of our RPDs are well seasoned. 2 of us are 10 plus years with residents under our belt, and another with over 20. Looking at the differences in the new standards, we expected it to be a little rocky, and I think unfortunately we were also somewhat shocked at the number of citations after the fact. We are in our process right now for our response, and recognizing with 3 major holidays, it's quite a lift that we're working on at this point. All 3 of our RPDs are practitioner surveyors. In particular, one of our concerns is that it felt like many of our partials were very consultative or subjective in nature, and just asking for the group to think about how that might look in the future if those consultatives were removed in order to make less work. Our group received 2 to 3 times as many citations as we have on our multiple previous surveys. And again, recognizing it's a new standard, but feeling that the 3 of us are, again, as practitioner surveyors, relatively well-versed in how to prepare and how to respond to these things. It felt like a lot of pre-work and perhaps somewhat superficial during the survey. Not enough questions asked of us perhaps to dig in, because as we look through what we're getting ready to write, we have this, we have this, we have this. So perhaps a survey to the programs after the fact to give feedback on how the process went would be our request.
Any comments from the? Do agree about a survey, post-survey.
I know, an extra survey, right? But
no, we do agree that there should be something, and it is noted that taking away consultative isn't. We don't want to increase other citations, so that's something we're going to take back to discuss that. So appreciate you bringing that up here, because it gives us food for thought and helps us as we move forward with the idea that it's a collaborative process, and how do we get through it in a way that is meaningful and not doesn't seem like busy work.
Thank you.
So I appreciate it.
Hi, Katie Karkowski, PGY2 Oncology RPD for Dartmouth Health in New Hampshire. I have hopefully an easy request for Pharm Academic related to timeliness of evaluations. Currently, I have multiple calendar reminders to check to make sure my preceptors submit their timely evaluations, and then I have to manually go in and run a report. And I was wondering if it would be possible to automate that through Pharm Academic and have the option to set up timed reminders or notifications to the RPD if an evaluation has not been submitted on time or within the 7 days of the due date.
I'm looking at my Pharm Academic thoughts. Is Mitzi around? Where's? There she is, hiding in the back. Thoughts? You, Andrea?
So I think Pharm Academic has, tried multiple things regarding timing of reminders, more, some less. But we're always willing to take your feedback and look at ways we can improve Pharm Academic for RPD. So maybe we can catch up afterwards, and every year we kind of put together a list for things enhancements, and we're always looking for things that can help you.
Thank you.
While Mitzi's heading over there, I'll take the question over here.
Hi, my name is Dexter Weimer. I'm the Residency Program Coordinator at the University of California, San Francisco, and for the PGY1 program and the PGY2 Director in Critical Care. I have what I hope are probably 2 easy suggestions, hopefully. The first one being ASHP is a source of information that a lot of people go to when they're looking for residencies and looking to learn about residencies. So since we already centralize a lot of that information about programs, is there potential that we as programs could upload the dates and links that we're having open houses and have that in one centralized place instead of relying on the candidates going to all the individual sites? As a suggestion. And then my second question / opportunity, I think, is around as we use Pharm Academic more for the centralized source of truth for everything, Is it possible that we could do some audit and feedback or task force creation around some of these tools that we're putting into Pharm Academic, such as the resident development plans? Because we're using that kind of as the resident's ticket to ride to all of their rotations, and our preceptors rely a lot on that piece. And I don't think we have the answer to what the best development plan looks like, but I'm sure that collectively the people in this room and the people that have left for other commitments from this room do have that answer. And I think it would be valuable to put together a task force before we actually program that in the future for everyone to use.
Yeah, so we do have a task force that Mitzi runs and Andrea is taking over. So we do have a group that looks at some of these things. Now our goal is obviously to make it as easy as possible for us to do. We did have a very nice whiteboarding session with Pharm Academic this summer where they came into ASHP. We got to sit with them and kind of whiteboard on things that we want. Everything we've heard about evaluations and how to make that a little bit easier, and how do you have dashboards so you can kind of see what's going on with your resident in a one-stop shop. So we have all these things in motion. It may take some time to get there, but I hear what you're saying. I'd rather go to the folks that actually use the tool than us trying to come up with the solutions ourselves. Mitzi, do you want to comment at all about the group that you and Andrea, either one, that we have for Pharm Academic?
Sure, I can comment about the group and then also follow up a question about timeliness. Someone? Yes, someone asked a question about timeliness. Let me do the timeliness one first, and then we can talk about the group. So from the timeliness, perspective, no one's ever happy about how many times. Some people want to get all the reminders, and then we get, don't remind us. And so we kind of go back and forth and back and forth. And finally it was decided, let's just select it and go. So in I think it's quarter 2 coming out in 2025, there will be a new reminder system. And I think you're going to get a reminder to complete it. I think it's 7 days before reminder, and then a post 3-day reminder like afterwards. I think that is what I recall. If Jennifer is in the room and she's like, no, that's not right, she can let us know. But quarter 2, 2025 is when that's going to go into place. Sure. Okay, so the question at hand is who gets the reminder, the RPD, the preceptor? I really, at this point, can't answer that. Jennifer, are you here?
Well, we'll detail that answer out for you.
You will find out because there will be notifications sent. It'll come out from Pharm Academic and like an enhancement or via like the communique about what that's going to look like. He'll get the reminders and the timeline. Regarding the group that looks at functionality and like the enhancements that we do, Pharm Academic does for us, we do have an advisory board, and they meet at least twice per year or as needed to kind of go over the budget, what we can do, what the needs are, and they are like RPDs of various size hospitals, like institutions throughout the country, and they help us, decide what the enhancements are. But also, Pharm Academic keeps track of all those questions you guys send in. So when you write in and say, what about this, or how does this work, or how do we do that, they're actually tagging those, and they're running a report. They're getting that back to Andrea, and then we're able to then, rank those and come up with a functionality, like enhancements. Okay? Thank you.
Great, thanks. Last question.
Hi, my name is Kelly Sheik. I'm the PGY1 RPD in the University of Toledo Medical Center in Ohio. My question is about the annual preceptor survey. And as a survey that, as an RPD, I have to make sure that 80% of my preceptors fill out. I don't actually know what happens to that information, and I know I don't get that information back for our program. When I email my preceptors, I make sure I say, hey, if you have any feedback, please let me know. But other than that information just kind of seems to disappear into the abyss. So I don't know if you guys can shed some light on where that information goes, or if there's a way to somehow get some sort of, aggregate data back to the RPDs so that we can use that information usefully for our programs.
That's a great question, and I think at this point that is part of the new dashboard that is available to RPDs. From that standpoint, though, it is aggregate data. It doesn't go back into an individual program for individual responses, and Some of that is because we've got larger programs, we've got smaller programs. It'd be kind of easy to sort of track that back. But some of that information is available in an aggregate form through the dashboards, which is a new enhancement this year in Pharm Academic. So take a look at that. But if you have more specific questions, reach out and I'm happy to help with that as well.
All right, guys, at the top of the hour, thank you for spending 2 hours with us. Thank you for your time and all that you do for residency training. Very much appreciate you all.